is focused on building a recovery bench. So building and educating recovery advocates about best practices and evidence. Our associate director, Professor Weissman, who also teaches in our program, is in long-term recovery and has built out a recovery group to expand access to best practices for and knowledge about best practices for that area of addiction policy. We also do quite a bit of research, but all of our research is really intended to drive better policies in this area. And we work on areas where, where we find the niche of the Americans with Disabilities Act, for example. Americans with Disabilities Act is a really important tool that can drive change in disability for people with disabilities, but it is often overlooked in terms of the opportunities it has to drive change for people with substance use disorder who are protected under the Americans with Disabilities Act. And I'm going to talk about that in a bit, but that's some of the work we do there. And Elizabeth, if you could advance the next slide. Secondly, as Professor Myers pointed out, we have a Master's of Science in Addiction Policy and Practice program at Georgetown. And we have our second cohort this year. Our first cohort graduated in July of last year. And the reason for starting this program was because so much of our addiction policies are based on fiction or based on the I knew a guy approach to addiction policy, that I knew a guy who had entered recovery because of this type of treatment, or not based on science and evidence and fact. So we combine training in science and research practices, as well as how to be an effective advocate. And so we're really happy that we have our second cohort this year, who really over the long term, my personal goal is to hold the door open for people in the addiction policy field so that they can go on to advance even better policies in this area. Next slide, please. So what I want to talk about today, and I think this answers some of the questions that some folks have put in the chat, is really what works. What do we do? It looks like it's an overwhelming problem. What can we do? And I'll talk a little bit about the work that we did in the Biden administration to advance these practices, and then what are the opportunities for next steps. Next slide, please. So I'm sure you all have heard about the increasing rates of overdose death in the country. Now we're at a rate, this is the most recent data from the Centers for Disease Control and Prevention. It's predicted we'll have year to year, August to August, about over 100,000 people have died. And you can see, so I started working in the Obama administration in 2009. And at that time, we had about 20,000 overdose deaths, which was pretty astronomical, or so we thought. And now we're faced with over 100,000 overdose deaths. Next slide, please. And the majority of these overdose deaths are driven by illicitly manufactured fentanyl. So you can see the change here. We started seeing illicitly manufactured fentanyl showing up in the drug supply in about 2015. So any opioid includes synthetic opioids such as fentanyl and prescription opioids. Heroin use and heroin-involved overdose deaths have gone down. But what we're seeing is this sharp increase in availability of synthetic drugs, and fentanyl in particular, illicitly manufactured fentanyl. Illicitly manufactured fentanyl comes, now it comes through Mexico. For a time, it was coming from China through the post, but most of it now is coming at the ports of entry through Mexico. So, synthetically manufactured fentanyl, unlike heroin, you have to grow a crop. Fentanyl, you don't grow a crop, you grow it in a lab. You develop it in a lab. And I really believe that, fentanyl as a synthetic drug is just the beginning of this. It's not even a trend anymore. It is a reality. We're going to see more and more synthetic drugs entering the marketplace just because it's cheap, it's fairly easy to manufacture, and you don't need like huge fields of coca or poppies to develop them. Next slide, please. So these are the national trends, and it's been 5 months in a row that we've seen overdose deaths go down. I am never, 5 months doesn't make a trend, but we are seeing a decrease in overdose deaths as individuals who use drugs adapt to the market, adapt to the availability of fentanyl. But also, and I'm going to talk about this in a little bit, there's been an unprecedented amount of money that's going into states to expand access to treatment, prevention, harm reduction, and recovery supports. And it is interesting to me to see, we're going to talk about this in a bit. So American Indian populations have had big increases in overdose deaths. You see that in Oklahoma on this map. And also other parts of the country. West Virginia is still one of the top 10. DC is still in the top 10. So those are, some of the 5-month snapshot that we're seeing. Elizabeth, next slide, please. As I mentioned, we have seen, when you think about opioid overdose deaths, when it started, it was typically the average person who was dying of an overdose was a 45 to 55-year-old white man from Appalachia. That was the issue in 2009, in 2010, 2011. What we've seen the last several years is a real change in who's dying from overdoses. And some of this is because of poly substance use. So methamphetamine use has gone up, and we're seeing fentanyl, illicitly manufactured fentanyl, throughout the drug supply. So the illicitly manufactured fentanyl could be combined with someone's meth. It could be that someone is using it. Oftentimes people who are unhoused use a substance during the day to keep them up, or at night to keep them up, and during the day, we'll use opioids so they can sleep. So there's a lot of polysubstance use. But again, it is shocking increases in American Indian populations, Black populations. We're seeing that also in Washington, D.C. And you don't think of D.C. typically. The general public, the media, isn't portraying D.C. as in the top 10 of overdose deaths, but it is. And it's primarily Black men who have a history of heroin use disorder, who live in wards 5, 7, and 8. So primarily east of Rock Creek Park, for those who know DC. And then also we have seen an increase in, as they say here, in the Hispanic population, overdose deaths. Overdose deaths have gone up across the board, have gone up, but these spikes in American Indian and Black populations are really noteworthy. And they're a combination of factors. They include the fact that Black populations have, for example, if you compare a Black person with a white person, regardless of socioeconomic status, it takes a Black person 5 years longer to get treatment. So there's a lot of systemic factors that we need to factor into this, these disparate rates of overdose death. Next slide, please. So this is a slide from the National Survey of Drug Use and Health that just came out. The National Survey on Drug Use and Health is an annual survey. Unfortunately, I can't show you the trends because they change the definitions in the survey. But what I wanted to point out to you here that I think is really important, I'm going to focus on overdose deaths, but really the #1 drug that's used in America is alcohol. And so if you see, and this is according to the Diagnostic and Statistical Manual 5, of, what the diagnoses are of alcohol use disorder and a drug use disorder. It's alcohol first and then all other drugs second, often in combination. So these are not, someone who uses meth may also be drinking, et cetera. They're usually additive. They're duplicative rather. So, but it's, these are the number of people who have various forms of substance use disorder. Next slide, please. I want to point this out because I think there's been a growing awareness of this issue, but we had until 2021, 2020, we had record low rates of illicit drug use among adolescents. This is from the Monitoring the Future survey. This is an annual survey that's done of 8th, 10th, and 12th graders. So 2021, record low rates of drug use in the United States. And also, I did not show this here, but also alcohol use. But at the same time, Elizabeth, you can show the next slide. So at the same time, we had a huge increase in overdose deaths in the same population. So if you look at on the left side, overdose mortality among adolescents by substance type, look at that huge increase. And then certainly they are not the majority of people who are dying of overdose deaths, but these are stark figures. Then on the right side, you can see that, again, American Indian, the Black and African American rates were not as high, but American Indian very high. And the overdose deaths are because of illicitly manufactured fentanyl, as I mentioned. And this is so 2021, when this was happening, a lot of this population that were getting the drugs, and it's about 900 people annually, they were primarily getting fentanyl by purchasing it over a social media channel. And at the time, they were not seeking out a pressed pill that contained fentanyl. They were purchasing something that they thought was something else. They were purchasing something that they either thought was Adderall. They might have thought it was, a pain reliever, but they weren't seeking out fentanyl. And these are not individuals, they may have experimented with drugs, but they were not necessarily people with a long history of substance use disorder. Certainly 14 to 18-year-olds are usually at the beginning of substance use. They had not developed a chronic, for the most part, had not developed a chronic condition where they were out seeking fentanyl. But the pressed pills that you could purchase, and we've seen next slide, please. We've seen this huge increase in the supply of pressed pills in the United States. So as I mentioned, fentanyl is very cheap. It's a lot cheaper than heroin. It's cheap to produce. The products, the precursor chemicals that go into creating fentanyl are pretty cheap. The majority of the precursor chemicals are coming from China. Not all of them are illegal substances, which is what makes it kind of difficult to ban because some of them are substances, precursor chemicals that are used for other products. But this huge increase in pressed pills coming across the board, it's not only across the border, it's coming at other ports of entry, coming into the United States. And so we're finding this, and this is a good point that someone just raised in the chat that we can talk about. So we're finding this increase and this increasing awareness of pressed pills containing fentanyl that are leading to this increase in overdose deaths in the adolescent population, at the same time that we have a decrease in substance use in this population. Next slide, please. So when we look at how we get here, the Centers for Disease Control and Prevention always talks about the 3 waves of overdose deaths, starting first with prescribed opioids, which led to a lot of laws to crack down on prescribing. So certainly, and Dr. Adrienne Few-Berman is an expert on this. I'm sure you'll hear about this. We saw a huge increase in prescribing rates of opioids because for a number of reasons. A lot are being litigated in the opioid litigation against drug distributors and manufacturers right now. And then as we saw, so what happened was, we did a good job, an appropriate job of reducing opioid over-prescribing. But what we didn't do at the same time was increase access to treatment or increase screening so you could identify people who might be at risk for risky substance use, or not doing a great job of identifying those trauma and risk factors, which include trauma that can lead to early substance use and subsequent substance use disorder. So as we ratcheted back availability, heroin availability increased. And so we saw this increase in heroin overdose deaths in the United States. That was the second wave of overdose deaths. And then we have this most recent wave. And the most recent wave involves synthetic opioids, which I've mentioned repeatedly, illicitly manufactured fentanyl. And it's not that, and I was in the Obama administration at the time, we could see these trends. We heard about illicitly manufactured fentanyl availability across the country. It varied in availability. Drug markets tend to vary. Trafficking networks tend to vary. But we started seeing these early signs, starting in New England. Press pills have primarily been across the southwest border and on the West Coast for the most part. But we started seeing these signs. And again, it is an opioid. You can use the same types of treatment for heroin use disorder, prescription opioid use disorder. You can use the same types of treatment, but ratcheting up that treatment access and the prevention piece through addressing social determinants of addiction, those are the areas that, we really had to turn to. Next slide, please. So, and for those of you who are interested in advocacy work, so as was mentioned, I've spent quite a bit of time in this area. I started, when I worked in the Seattle mayor's office, and then prior to that on various policy issues. So I've been an advocate on this for a really long time now. And the one thing that I would encourage folks is to stay engaged and not think of this as activism tourism. If you say that something should change, that means you have to be willing to put the work in, and the work might take quite some time. And so, and it was all, so we started laying the groundwork for a lot of these reforms in the Obama administration. And then I served on the transition team for the Biden-Harris administration. And I also helped any Democratic candidate who was interested in this issue. I helped them formulate their policy plans so that we could get in these issues that we thought that, that really needed to be done to address to make the change and the reforms that needed to be made. So the first year of the Biden-Harris administration, I started serving the afternoon of Inauguration Day. So just last week in 2021, I entered the office. And because I had served on the Biden-Harris transition team, we were able to start the work on day one. And in April of that year, we had to issue our drug policy priorities. And again, these are things that we'd thought about for a really long time. And so we were able to advance them. You can't, you have to also look at shifting conditions on the ground. But some of these issues are really, they are evergreen. So the first is expanding access, not just to treatment, but to treatment that actually is evidence-based. And defining that evidence base, making sure that evidence base is informing policy and on the ground. The second is advancing racial equity issues in the approach to drug policy. And that spans the list of things from, the criminal legal system, as well as looking at issues such as the majority of people with opioid use, Black Americans with opioid use disorder are getting, if they get any treatment, they're getting methadone, not buprenorphine. How can we look at that issue? Enhancing evidence-based harm reduction efforts. Now, this marked the first time an administration had ever literally used the term harm reduction. It had never been in any other plan because it was open to interpretation. But now what we wanted to do was show that if the vast majority of people who may have a diagnosis of a substance use disorder or may not have a diagnosis of a substance use disorder, if someone with a substance use disorder is not getting treatment, they still deserve services that will reduce the harms associated with drug use. And that may include syringe services programs. That includes an array of services so that they don't have to suffer the other ill effects that often accompany a substance use disorder that go untreated. The fourth is supporting evidence-based prevention efforts. And again, that goes to advancing the other issues that you wouldn't think: poverty, trauma. All those issues go into increasing people's risk for a substance use disorder, but they're often bifurcated and siloed away from the work that we do. Housing, employment, all those play a role in the social determinants of addiction. Reducing the supply of illicit substances. And I know that that's not something that, is often talked about on domestic policy reform. But if you look at drug trafficking networks, not as a neighborhood dealer, but as an international criminal enterprise that traffics in not just drugs, but fuel and people, and they use illicit finance to promote their work and to advance their work. These are international criminal enterprises, and that's what the reducing the supply of illicit substances work is. Advancing recovery-ready workplaces. Many states around the country are looking at this. What this means is that you work in a place that, first of all, respects the fact the Americans with Disabilities Act protects people who are in recovery from a substance use disorder, and that if someone in your workplace has a substance use disorder, you can use your health insurance and employee benefits programs to get them the help that they might need. And if they're in recovery, getting them the supports that they may need so that they can retain their employment, they can stay employed, because that will reduce costs not only for taxpayers, it also helps individuals if they're employed. It expands their ability to continue in their recovery, and it also helps workers, the workplace itself. And then lastly, expanding access to recovery support services. So again, that means employment, making sure that we have ban the box policies for those people with substance use disorder who have been involved in the criminal legal system, that they are able to be employed, because that is one of the indicators of sustained recovery is a job. And other recovery support services, including housing, childcare, all those other issues that go into that. Next slide, please. So in the Office of National Drug Control Policy, where I worked for a total of about 9.5 years, has to put out a national drug strategy. So last year, they put out the National Drug Control Strategy, and it includes a lot of the pieces that we had in our initial drug policy priorities. Next slide, please. So what I want to discuss in the next, the remainder of the time, is how you make this happen, and what are the policy opportunities, and how do you effectuate these policies. So we talk a lot about low-hanging fruit. What is a low-hanging fruit? In my mind, low-hanging fruit are things that you can get done easily. They're not necessarily the things that and they're important, but they're not necessarily the things that are the that are always that will be able to be done in 6 months or a year. Many things that are important will take a longer period of time, but you can use various policy levers, and these are the policy levers that can be looked at, because I think often we look at just Congress has to do it, but there's a lot of other policy levers that I'm sure you're learning about in your other seminars. So first, executive action. Really important piece of, so there's executive orders that can be done. Now, the executive orders are important. They establish policies. The challenge with executive orders is that a next president, if that president does not agree with the executive order, or a mayor or a governor, they can rescind those executive orders so they go away. But that can be used as a tool to advance certain policies. The other piece is regulations, and we're going to talk about the methadone regulations that have been introduced in the last couple months. The regulatory piece means that you're looking at solutions that don't require congressional action. Congress has already passed something, a regulation has already been implemented, and if that regulation could be changed, so you're looking at whether or not the regulation can be revised based on what's already been passed. But these are within the authority of the executive branch, and it's a really important tool. The second is legislative action, and this is a tougher road. I'm going to talk briefly about legislation that passed last year. What we think of typically is that, and you look at how a bill becomes a law, legislation is introduced, there are hearings, amendments, there's a process. What's happened lately is that a bill is introduced, there might be a hearing, there might not be a hearing, and then at the end of the year, there's an omnibus where everything is thrown in. And I'm going to talk about what happened last year, in which a lot of legislation that had been discussed for the last couple of years was put into a last-minute piece of legislation. Now, the challenge and the reason that's happening is because there isn't a bipartisan consensus, because really to get legislation to happen, legislative change that is sustained over time, you need a bipartisan agreement on it. You also, on the federal level, you need an agency consensus. So the Office of National Drug Control Policy is within the executive branch of the president, and it's in the executive office of the president. But it has budget authority over the Health and Human Services Agency, as well as the Drug Enforcement Administration. So to get anything to happen, you need the Drug Enforcement Administration, the Department of Justice, and Health and Human Services to agree on a course of action. That's also really difficult to to make that happen. But really, if you want sustained, lasting change, you need those two pieces. And then lastly, enforcement. And we don't often think of this as a policy tool, but it really is in a couple ways. First of all, the Department of Justice has a lot of authority over the Americans with Disabilities Act, enforcing the ADA. So the Department of Justice put out guidance last year that discussed the applicability of the Americans with Disabilities Act to people who are incarcerated who were on medications for opioid use disorder, and said very clearly, if you have a blanket policy telling people that if they're on a medication for opioid use disorder, let's say methadone or buprenorphine, that when they come to a jail or prison, they have to get off, that is a violation of the ADA. And so there's been litigation brought nationwide on that issue. That is a way to drive policy change also. And then the other piece through enforcement is parity enforcement. So the parity law passed that said that if you are an insurer that provides physical health care, you have to provide the same level of benefits for mental health and substance use as you do for someone with a physical ailment. And that falls within the Department of Labor Authority, as well as state insurance commissioners. That's another way to drive change. So those are all policy tools that can be used to get to the end of the day where you're getting reforms that last. Elizabeth? So In the first year of the administration, there are a few things that we did to make sure to use these policy levers to get to those policy priorities that we had. And, so after I left the Obama administration, I came to Georgetown, and I was able to kind of think a lot about, what does the research say and how do we drive policy? And that was a nice thing to do. A lot of people who work in administrations do this. They, take time off, they will research, and then they go back into the government and they can implement those changes. So a couple things that we did. First was there was a policy paper that was put out by an agency in HHS that said that you could not spend federal money on fentanyl test strips. Fentanyl test strips are just what they are. They're drug testing strips that test for the presence of fentanyl. Now, we know that all drug right now, if you buy an illegal drug, it's most likely to have fentanyl in it. But, we thought it was an important message to send for a couple of reasons. One is because there was no policy reason, there was no science reason to have a federal ban on this. It was just it was gratuitous and unnecessary. So all we did was we took the blog down. I mean, that was one of the simplest things that we did. We did that a couple months into the administration, got that done so that people knew that, number one, there might be fentanyl out there in your drug supply. And secondly, how to use a fentanyl test strip. The other thing we did was, after a decade, was finally get the mobile methadone units to be able to, for treatment facilities, to be able to use mobile methadone vans. So if you have to distribute sometimes buprenorphine, but mostly methadone. And we saw this as an opportunity to extend treatment in rural areas of the country that might be a treatment desert, but also to jails and prisons that wouldn't otherwise have access to methadone. And then also in the American Rescue Plan included a $30 million specific grant program for harm reduction services. 30 million certainly isn't sufficient, but it was the first time there was a specific harm reduction grant program that could fund syringe services programs and other harm reduction programs across the country. Now, it was raised in the chat that, there are states in this country that still outlaw drug testing, including fentanyl test strips, and they're considered drug paraphernalia. And so again, what the federal government can do, and I truly believe this, having worked in the state and the local level, is that the federal government can send a message about things. And so after this fentanyl test strip ban was overturned on the federal level, there were many states that changed their drug paraphernalia laws to allow for fentanyl test strips to be distributed. DC was one of those. And so you can get fentanyl test strips in DC in many areas of town. Next slide, please. So I talked about the end of year legislation, and this happened. So the omnibus legislation that passed in December of 2022, it funded the government, which was a good thing, for 2023, for fiscal year 2023. But it also included some, very significant policy changes. And I'll go over those in the brief time I have left. So the first was the Mainstreaming Addiction Treatment Act. So what that did is, if you are a prescriber, a holder of a controlled substances license, prior to this week, you had to, if you're going to prescribe to more than 30 patients, you had to have an 8-hour training if you're a physician, and a 24-hour training if you are a nurse practitioner or a physician's assistant, to prescribe before you can prescribe buprenorphine, which is one of the 3 medications to treat opioid disorder. So in the 2022 omnibus, they included this legislation. No longer do you need a specific waiver to prescribe buprenorphine. And the argument against it was that you don't need a specific waiver to prescribe any other type of opioid except for buprenorphine. So that was a very significant change. That is not going to make every physician just wake up today and say, I'm going to start treating my patients with addiction. But it sends the important message that it is part of advancing public health, is making sure that we're treating people with addiction. And there were a couple other very significant pieces in here. The second one was the MATE Act. Now, the MATE Act requires for all controlled substances license holders to have a one-time training on addiction. And so the purpose of that is, again, if only about 10% of people with substance use disorder have treatment, the idea is for physicians to be able to spot risky substance use, as well as to be able to diagnose and either treat themselves or refer people for treatment. And the details on that education piece are to be determined, but that was a very significant piece as well. If you could go to the next couple slides, please, the next slide. So I'm not going to go into great detail on this, but the methadone proposed rule, a notice of proposed rulemaking came out the end of last year. Comments are due in the next couple weeks. This is the first time the rules regarding methadone have been opened for decades. And the reason this is important is because methadone is a long time, it's been known for years how effective it is at reducing overdose deaths, helping people with opioid use disorder live full lives. But it was treated it was presented to people as if it was a punishment. If you're not stable yet, you have to go every day to a methadone treatment facility. And it was done from a very legal perspective as opposed to a clinical perspective. So these new methadone rules are out. And again, if you look at the policy levers, this is one of those policy levers that was obvious and could be used to change how our approach to treatment. Next slide, please. So the way forward, there's still a lot of work to be done. I'm really excited about the opportunities that are before us because there's been so much work done in the last couple of years. We still need to look at how we're going to prevent substance use disorder by looking at those social determinants of addiction. We still need to do more to expand treatment access to people, scale up harm reduction, expand the Americans with Disabilities Act, look at criminal legal reforms, and there's two other pieces of policy that remain undone. The first is the crack cocaine sentencing disparity still exists. It's 18-to-1 as opposed to 100-to-1, but it's still an unscientific approach to someone who has is charged with possession of crack versus possession and sale of powder cocaine. And then secondly, the inmate exclusion. That has to be done by Congress. If you're an individual who is incarcerated, you lose you are on Medicaid, you lose ability to get Medicaid federal matching funds when you're incarcerated. So your healthcare services are people who are incarcerated are much more likely to suffer overdose deaths as well as other health conditions. So that's another remaining piece that needs to be done that Congress has to consider, hopefully will consider in this legislative session. Next slide, please. And then lastly, I always leave every speech I give with the reason why we're doing this is because of the over 100,000 people in this country we lose every year to overdose death, not to mention the number of people who have suffered overdoses and their families and communities. And that's why we're doing this. And I thank you, and I'm happy to take any questions you may have.
Okay, so Sophia will moderate the question and answer session now, starting with students in the program, and then she'll include others. So feel free to raise your hand or put things in chat If you're a happy student, you can follow. You'll be selected first. So Sophia.
Yeah, so I was gonna say I saw a lot of questions pop up in the chat if we wanted to start there. So Björna, you had a question about resources for separating myth from fact.
I think that Professor LaBelle covered that. I think I'm good with that. It was just something that I think about often when I do hear a lot of questions. It's just like, which resources should I point to as like a health advocate? So if you have anything more to add in terms of like, if there's any place that has like the best fact sheets or just something that I can use when people do have questions about it.
Sure. I think, the Substance Abuse and Mental Health Services Administration, SAMHSA, has good materials, as well as the Centers for Disease Control and Prevention. CDC has probably more on harm reduction services because they've been doing syringe services programs for a long time, but those are two sources that you can look at.
Okay, thank you.
I'll go to the next question in the chat, which was from Matt. What are your thoughts and opinions on effective harm reduction strategies, specifically safe consumption / injection sites? Matt, do you want to add anything to that?
No, I think that's about right. I'd just love to get a better idea of strategies that you personally believe are effective within harm reduction. And then, yeah, just specifically if you have any thoughts on safe consumption sites.
Sure. So I think when I think about harm reduction, I think about I think of it in two ways. The first is that it's kind of a philosophy and an approach, and it means that we should treat people with dignity and take them and meet them where they are, but not leave them there. So that's kind of a philosophical approach to harm reduction that I really strongly believe in, and I think that anyone who works in this field should be, trained in, physicians, healthcare practitioners, the criminal legal system, et cetera. But the second piece of harm reduction is obviously those services. So they range from syringe services programs, which are still illegal in states. And someone mentioned fentanyl test strips, drug paraphernalia laws. I mean, we're not where we should be on harm reduction services, because again, it shouldn't be a one strategy. It needs to be an all of the above strategy. So again, how do we prevent substance use disorders from occurring? How do we prevent youth substance use? How do we make sure that people have access to quality treatment, to harm reduction services when they need them? And then also those recovery supports, that all has to be part of the continuum of care. Now, the various approaches, there's research that's occurring on overdose prevention sites. They're also called safe consumption sites. Rhode Island passed a law that would allow them. The city of Seattle had money, and King County, Washington, had money that would appropriate it. Governor Newsom in California vetoed the law. I think I don't think every community is at the place where they believe safe consumption sites or overdose prevention sites are the solution. There's a scaling issue. New York has two, San Francisco has one. I'm a little concerned right now that there's a lot of pushback on some efforts, like in San Francisco over their site. So again, it's an all of the above strategy as opposed to just one. But we do have research from Vancouver and other countries about the benefits of overdose prevention sites. But I would say that our whole thing isn't just about preventing overdose deaths. It's really improving outcomes for people with all forms of substance use disorder.
Thank you.
So next in the chat is a question from Bronwyn. She asked, is safe supply a good option for harm reduction?
So, so safe supply is typically defined as, basically it's defined in a couple different ways. And Vancouver, British Columbia is kind of experimenting with this now, where, you have, it's basically like a legal supply of drugs that you can access if you have a substance use disorder. So that it's not tainted. And people have made the argument that it's akin to when alcohol was prohibited, there were tainted alcohol supplies. So, British Columbia is looking at this right now as part of their harm reduction strategies. And their Canadian laws are, I guess, flexible enough to allow this to happen. What some states, the United States, are doing is they're partnering with researchers to test at syringe services programs. They're testing drug residue so they can warn people about what's in it. But the taking the substance, testing it, and handing it back by the state, or something right now in the United States, that's not something that's legally allowed, but certainly British Columbia is looking at that.
Bronwyn, did that answer the first question that you had?
Yes, I was just kind of wondering your thoughts on it. I know some people that work at one of the safe supply places in British Columbia, and they think it's making a really good difference. So I was just wondering your thoughts on it.
Okay. The next question is from Tara. She was asking generally about harm reduction options and how to get the proper strategies on the policy agenda.
So, I think that some of first of all, it's identifying, identifying the outcome, the goals, and the steps to get there, and then looking at these various policy levers, and not being afraid to find partners and other stakeholders who can help you accomplish your goal. And, kind of thinking again over the long run, what's it going to take for you to get this and to be sustained and lasting change?
Kara, did that answer your question?
Yeah, thank you.
And then going back to Bronwyn, she asked, how do you think the import of fentanyl is contributing to xenophobia in the US?
Yeah, these issues, when they become politicized, never win for anyone. And we've seen, it's being used as a punching bag right now. And the solutions, the majority of fentanyl that's coming across the border is not being carried in by migrants from Venezuela who are asking for sanctuary here. They're coming in vehicles for the most part. Some people are carrying it, but it's not the bulk of people. There are other issues, again, corruption. Venezuela, it's a lot of the immigrants are coming from there. So I think it is contributing to xenophobia. But again, we look at these issues are complex, and it takes a long time to really accomplish change. But I think we look for the easy fix, something that's going to fit in a short tweet, or something that's going to be, a good soundbite on the news. And that's not what works.
Bronwyn, again, did that answer your question? Or
Yes, that was perfect. I agree with you.
So the next question is from Matt. Thoughts on decriminalization of all substances?
So can I go back to the one before that? I will answer this, Matt, but the one about the control of fentanyl in China is strict.
Yeah, sorry, I was confused. I didn't
Oh,
know
no,
if
it's
it was
okay. Sorry, I'm micromanaging.
It's all good.
So China in 2015 did ban the export of fentanyl, but again, it's about precursor chemicals. So a lot of the precursor chemicals coming from China are going to Mexico, and so that is a we know that that's where the chemicals are coming from. They're coming from China. The United States has banned, and in the legislation, the United States has banned fentanyl as a class until 2024. So it has met the same conditions. The issues are complicated by the fact that China, as you know, has a huge chemical industry. And so it does not always control the flow of these precursor chemicals that are going into the manufacture of fentanyl. And that is why it is a complicated, issue.
Thank you. Thank you.
Thanks. Sorry.
No, sorry about that, Eva. I didn't read I read your question as a statement. That was my bad. I apologize.
And then
Okay, so next question from Matt, and your thoughts on decriminalization of all substances.
Yeah, so I think what's really interesting is, or not interesting, but I think it's important that we define decriminalization. So the decriminalization, which is basically what they're doing in Oregon, versus commercialization, which means that, what is happening in many states with cannabis companies that are producing and selling their cannabis. So decriminalization, we're going to see what happens, right, in Oregon, how it happens. And I think what's important is, yes, Portugal has decriminalization. It does have some criminal penalties associated with certain offenses, which go beyond possession. But they also have, a much more robust health insurance system than the United States does. So we're going to see what happens in Oregon, rather. I think there'll need to be research done on what's working, what's not working. King County, Washington had a de facto decriminalization for like the last almost 10 years of possession. And that's where Seattle is located in there. The prosecuting attorney in King County wasn't charging for any possession charges of any substance for a decade. So, but the issue is we need to do more research on this, because we have to follow the science and evidence. And while it makes intuitive sense that people should not be incarcerated for possession alone, and I think that we all have agreed to that fact, what else, what can we do beyond that? What other services that are necessary? How do we look at our financing system so we are less siloed, so we're addressing people who may have concerns, needs, etc., in a holistic way?
In the chat, I don't see any more questions from happy students. Just asking generally, do any other happy students have any more questions? If not, I'll move on to our non-happy attendees. No. Okay. I had actually a quick question. More of a general broad question, and regarding parity, do you think that the increase in funding, or do you think it will fall flat? I'm just curious your thoughts on that.
I'm sorry, you broke up a little bit. I got parity and then I lost you for a little bit.
Yeah. In regards to parity, your thoughts on that and the increase in funding that parity has been given for the states, do you think that it'll make or have an effective outcome, or do you think it will fall flat? Do you think that we'll see a significant difference?
Well, we have workforce issues. We have a shortage of trained clinicians around the country, particularly in rural areas. So, simply giving more money isn't necessarily the solution. There are the money has to be spent wisely, and we have to invest in our workforce. So, the parity enforcement, but if the majority of people get their services through private insurance, it's not the majority. The majority of people with substance use disorder get their services through, federally paid services. But if that's the parity piece through private insurance is another way that we can build that workforce, because the needs are there and we have to grow that workforce.
Right. Thank you so much. Okay, so I'll go to BJ. I know you had some questions in the chat if you wanted to ask the same ones or you have new ones. The floor is yours.
Thank you. What sites would be best to utilize for best treatments as far as the research that has been done for best treatments?
Yeah, that's a great question. So there's a couple resources. So the SAMHSA has a treatment locator, but it says what's available. It's not like a quality scoring system. But you can go to SAMHSA's treatment finder and look for that. The second source is the second quality assurance program is done through Shatterproof's Atlas program. And they are in, I think, like half of the states now. So that's more of a qualitative approach to treatment, to look at the services that are available. And then there's all the accreditation programs, which do kind of, show the quality of a program. But I think that's a shortcoming in terms of, if you're a consumer, how can you really tell what's good, what's effective, what the outcomes are? That's what Shatterproof is working on right now. They're a nonprofit organization.
I'll go ahead and go to the next question in the chat. It's from Andrew. He asks, it was briefly mentioned that social media is used as a vector for obtaining fentanyl, whether intended or not. Is this currently an angle for preventing its use?
Yeah, so the federal government is, reaching out to these social media companies to find out what they're doing to prevent access on their channels. Social media companies, their response is, well, not much we can do. It's hard to tell. But yes, I think I personally think there is more that they can do to control the content on their social media channels. And I think there's a lot more they can do.
So the next question is from John. Any thoughts about the growing interest in treatment of substance use disorder and trauma via psychedelic assisted therapy? Additionally, any thoughts about the role of stigma?
So two big questions. The first is, I follow science. I mean, there is a lot of psychedelic research on psychedelics that's happening. I think what's really important is that, people do follow that science and make sure they're not like doing it on their own, or because there are, the researchers are showing the benefits, but also the risks. So it's important that it be done in a controlled setting with professionals, but, we need to follow the science on that. I mean, the second piece of stigma, this underlies almost everything we do, right? The fact that physicians, there have been surveys of physicians about why they don't treat people with addiction, why they don't want to why they didn't at the time want to get the data waiver to prescribe buprenorphine. And there are a couple reasons, but one of them was, I don't want those people in my waiting room. And those people are already in their waiting room. They're just not acknowledging it. If we have 23 million people in this country with a substance use disorder, chances are they're going to a healthcare provider right now. So, there's a lot that we can do. I think it's important that, one of the ways in which to get rid of stigma is by putting a face on it, is by getting to know people who are in recovery. And that's something that we try to do. When I was at the Office of National Drug Control Policy, Michael Botticelli was the director of the program, and he was a person in long-term recovery. It was the first time that there was a person in long-term recovery, openly in long-term recovery, in that position. So I think, having more people who can talk about this. He also was on 60 Minutes. And I know people who are in recovery who were just blown away, because it's not just about the stigma, it's also the self-stigma and the shame that we may feel, or parents may feel, that you were a bad parent if your child had a substance use disorder. So the stigma underlies almost every element of the work that has to be done.
The next question is from Rebecca. She asks, how effective is harm reduction strategy? Because some think that it can encourage drug consumption instead of preventing or minimizing use.
So I think it's important that we talk about that, if there is, what harm reduction really is. And there isn't any research that supports that it increases drug use. There's a lot of evidence on that syringe services programs in particular, which are harm reduction services, are more likely, people who use syringe services programs are more likely to seek out treatment because they're going to be offered it and they're going to be treated with respect. We also know that syringe services programs reduce bloodborne disease and bloodborne disease outbreaks, which occurred in Indiana in 2015. So I think it's important that we make sure we're defining what harm reduction services are, which is to reduce the harms associated with substance use, and also what the evidence shows about programs like syringe services programs.
The next question is from Robert. He asks, are there any resources to support peer education to prevent drug abuse? A high school student who would like to go out to schools where there is a high risk of drug abuse to help them avoid using illicit drugs.
I'm sorry, you broke up again. I was trying to see which question it was.
No worries. I apologize.
Support peer-to-peer education to
Robert.
prevent drug use in teens.
Yep. Mm-hmm.
So a couple things. One is that I think it's important that we start with youth prevention, even in adolescence, not necessarily just high school. And what is effective, so there are a couple effective programs that SAMHSA has pointed out. One is the Communities That Care model. Another is, I think it's called Talk, They Listen. It basically is a coaching program for parents, because parents are a really important prevention tool. And, I'm a parent. We may think, although I feel like this every day, that your kids don't listen to you. They actually do. And so, talking to them about substance use, talking to them about the risks of social media is also an important piece of this. So, there's the most effective programs of prevention are comprehensive. And the Communities of Care program is not just like a one-time event. It's a longer term program that involves communities. The Drug-Free Community Coalitions program is another one of traditional prevention programs, primary prevention that prevents youth, primarily youth, smoking and alcohol use.
It looks like the next question is from Blake. How is the approach of advocates changing with the new Congress? What sort of actions do you see as the most effective for researchers and advocates over the next few years?
So one thing that's really important, I feel like you need to not take the bait, because this is becoming so politicized, and there's a desire to make it about xenophobia or about, the border. And so when you go to the committee hearings, you'll hear a lot of kind of the baiting. And, it's important that you always keep in front of you those people who are in need of care. what's our bottom line here? And I think, the most effective way to do advocacy is to find something we can all agree on and moving forward. And sometimes that's really hard in this fraud environment, but you have to put aside your, our natural tendencies to become political about it and find those things upon which we can agree and build on that.
The next question is from Kat. She asked, how is the state opioid litigation fund spending connecting to the state and federal policies, or are they?
Yeah, so the state, opioid proceeds are being divided up. It varies from state to state. Sometimes it goes to local governments, some it's going, and also it's going to the state. What will be important is because the federal government has state opioid response grants, has SAMHSA block grant. What's really important is that they be coordinated. And so that's going to be a governance practice that the governors are going to have to do, and that the federal government's going to have to keep an eye on too. But I don't think that planning has been done yet.
It looks like those, well, hang on. Lydia asked, what is the title of the 60-minute show touching on stigma that you mentioned earlier?
It was from 2015, and I can, if you Google Michael Botticelli and 60 Minutes, you'll find it. I mean, the language is stigmatizing, but it was a while ago. But his name is Michael Botticelli.
So we are running out of time. Do you have any further questions out there that you saw, Sarah?
Those were all the questions that I saw.
Okay, great. I want to thank Sarah for moderating today. And it's a big audience today for our first seminar of the semester. I hope you all will stay with us. We got a really great lineup coming, and you'll be getting invitations soon for some of the coming ones. And Professor LaBelle, you have all of our admiration for the advocacy you're doing on behalf of people who suffer the disease of substance use. And I hope you'll come back another year to present on what you're doing and what your thoughts are as we experience the next couple of years of the epidemic, unfortunately.
Great. Thanks so much. Great to talk to you all, and have a great semester.
Thank you.
Bye.
Thank you. See you all next time. So